Hey guys, today we are going to discuss a critical but often overlooked topic in our fight against tuberculosis. Tuberculosis in older adults, the Great Masquerader. I'm Dr. Nabil Fayas and we will explore why TB in the elderly is a diagnostic challenge and what we can do about it. To frame our discussion, we will cover the key areas. We'll start with the epidemiology and unique pathophysiology in older adults, then move to the atypical clinical and radiological presentations that make the diagnosis so tricky. Finally, we will discuss the diagnostic challenges, treatment considerations under India's NTEP, and the specific outcomes we see in this vulnerable population. Let's begin with a crucial concept. TB in older adults is a diagnostic blind spot. This group faces a triple threat. They are more susceptible to active disease. Their symptoms often disguise themselves as the other age related conditions, and the treatment itself poses great challenges. Confronting this silent epidemic requires us to be deliberate and vigilant. When we look at the epidemiology, the numbers tell a compelling story. India carries the world's highest TB burden. Concurrently, our elderly population is growing rapidly. They are a recognized vulnerable group under the NTEP. The 2024 India TB report notified about 3.4 lakh cases in those over 60, but the actual number is likely much higher. A key driver is the diabetes TB syndemic, where diabetes increases TB risk 2 to 3 fold. The burden is high in states like UP, Bihar, Maharashtra, West Bengal, and Rajasthan, especially in the urban slums and tribal regions where the prevalence is very high and the adherence to treatment is very poor. This is why the NTP program is so critical. Its goal is to eliminate TB in India by 2025 by focusing on early diagnosis using advanced molecular tests, universal drug susceptibility testing, free treatment, nutritional support, and digital monitoring. Unfortunately, we are at the verge of 2025 and we have not yet climbed the ladder to eliminate this TB from India. Looking at the pathophysiology, why are older adults so vulnerable? The answer lies in immunosenescence. Their T cell lose efficiency, macrophage activation reduces, and cytokine response weaken. This often leads to the reactivation of latent tuberculosis bacteria rather than the new infection. Comorbidities like diabetes and CKD further blunt the immune response. The protection from childhood BCG wanes over time. A key result is paucibacillary disease, where the bacilli seed slowly and the disease can remain unnoticed for a long time. This paucibacillary nature is a core diagnostic challenge. Reactivation disease simply sheds fewer bacilli. This means we often see negative AFP smears despite active disease, leading to diagnostic delays and more advanced illness at presentation. It's vital to remember paucibacillary is a diagnostic characteristic, not a prognostic one. The disease can still be severe. So, what does TB look like in an older adult? Forget the classical textbook picture. Think atypical. It's often present as a general, non specific decline like weight loss, fatigue, loss of appetite. Look for functional decline, increased weakness, falls, and inability to perform daily tasks. The cough is often weak and persistent, mistaken for COPD or a smoker's cough. They may have no fever or a very low grade one. Sometimes the first sign is confusion or an altered mental status. This is truly a disease in disguise. To make it clear, let's contrast. In a young adult, we expect a productive cough, evening fever, and night sweats. In an older adult, the cough is weak and dry, fever is less pronounced, and night sweats may be absent. Symptoms like weight loss are often shrugged off as just aging. Importantly, dyspnea is more common early due to underlying COPD or heart failure, and we see non pulmonary flags like confusion, delirium, and falls. Extrapulmonary TB is far more frequent in older adults. Common sites include lymph nodes, pleural effusion, and the spine. These are all important sites. Apart from that, the genitourinary TB, meningitis, we must be especially vigilant for meningitis and disseminated TB, later carrying a high mortality in the frail elderly. Let's look at the radiological differences. The chest X-ray can be just as deceptive. In a young adult, we look for classic upper lobe consolidation and cavitation. In an older adult, the pattern is atypical. Think lower or middle lobe involvement, less cavitation, more diffuse infiltrates, and frequent pleural effusions. Miliary TB is also more common. This picture can easily mimic bacterial pneumonia or even carcinoma. Because of this, a CT chest is often indispensable for diagnosis, revealing patterns like tree in bud, lymphadenopathy, or miliary nodules that an X-ray might miss. This is the X-ray of an younger adult. You can see in the first X-ray, there is upper lobe consolidation of the right side, and in the second X-ray, you can see the cavitatory consolidation of the right upper lobe. In contrast, if you see the older adult X-ray, tuberculosis consolidation and cavitation, it is shifted to the middle lobe and lower lobe, and you can see the subtle pleural effusions in the second X-ray. So these are the things you need to look in an elderly patient like lymphadenopathy, lower lobe consolidation, pleural effusion, tree in bud appearance. What are the diagnostic challenges we have? Let's synthesize these diagnostic hurdles. We have atypical symptoms and radiographic findings. Their weak cough reflex makes obtaining a good sputum sample difficult. The disease is paucibacillary, leading to negative smears. Underlying lung disease can obscure new findings, and crucially, common symptoms like fatigue and weight loss are masked by other chronic conditions of old age. So, TB is not often the first suspect. Often, we need induced sputum or bronchoscopy. Just a few words on Montaut test. It indicates exposure, not active disease, and is only supportive. It can be falsely positive from BCG vaccination. More importantly, in the elderly, it can be falsely negative due to something called energy from advanced age, malnutrition, or immune exhaustion. It is not a reliable test for ruling in or ruling out active tuberculosis in this population. So, our diagnostic arsenal must be strategic. Beyond sputum smear, we rely heavily on molecular tests like CBNAT or expert MTB. Line probe assays and cultures are key for full drug susceptibility testing. Radiologically, a CT chest is often more revealing than an X-ray. For baseline and drug monitoring, we need CBC, LFT, RFT, vision test, and screening for diabetes and HIV. When managing tuberculosis in older adults, our aim expands. It is not just about microbiological cure. We must conduct a comprehensive geriatric assessment evaluating comorbidities, polypharmacy, cognition, nutrition, and social support. Our true goal is functional recovery and quality of life, not just microbiological cure. Treatment comes with inherent challenges: increased risk of side effects and drug interactions, the need for dose adjustments in renal or hepatic impairment, and ensuring adherence, often requiring DOTS and caregiver involvement. For drug sensitive tuberculosis, the standard regimen remains 2 HRST and 4 HRE. Let's recall key points. Isoniazid is bactericidal but can cause hepatitis and neuropathy. Give pyridoxine. Rifampicin is a potent sterilizing drug but a major enzyme inducer. Many drug interactions are possible. Ethambutol requires vision monitoring because of optic neuritis. Pyrazinamide, again, it can cause hepatotoxicity and hyperuricemia. For drug-resistant tuberculosis under NTEP, we have a structured approach. NTEP has grouped the second-line drugs into 3 categories: Group A, Group B, and Group C. Group A contains leoflox or moxiflox, baraquilin, and linezolid. Group B contains clofazimine, cycloserine, or terizidone. And Group C contains ethambutol, delamanid, pyrazinamide, imipenem cilastin or meropenem, amikacin or streptomycin, para-amino salicylic acid. Usually, these groups are used for the most resistant cases like XDR tuberculosis. The current NTEP standard for drug sensitive TB is a 6-month daily regimen. 2 months of HRST followed by 4 months of HRE. While older adults receive the same regimen, they require vigilant dose adjustment, monitoring, and enhanced supportive care. For some extrapulmonary sites like spine tuberculosis or CNS tuberculosis, the continuation phase may be extended beyond the prescribed period. MDR-TB is increasingly seen due to prior inadequate therapy. Regimens are longer with more side effects. XDR-TB presents extreme challenges, limited treatment options, high mortality up to 80%, severe toxicity, immense symptom burden, and profound psychological support. It forces us to balance aggressive therapy with comfort and dignity in terminal cases. There is hope with newer regimens. India has introduced shorter, more effective options. The BPAL-M regimen, bedaquiline, pritomanid, linezolid, and moxifloxacin, over 6 months has shown success rates up to 80% for eligible MDR-TB patients. For others, a longer 18 to 24 month regimen using groups A and B drugs is used. The choice is individualized. Let's look at the key geriatric considerations. Managing tuberculosis in the elderly requires specific modifications. We must adjust for altered pharmacokinetics and avoid hepatotoxic overload. Polypharmacy is a huge concern, especially rifampicint's interactions with drugs like warfarin. We must proactively prevent INH neuropathy with pyridoxine and monitor for ethambutol's visual toxicity. Adherence support via DOTS and addressing malnutrition are non-negotiable. Let's highlight the key indicators in drug-drug interactions. Rifampicin as a potent enzyme inducer reduces the efficacy of oral hypoglycemics, anticoagulants, statins, and steroids. INH as an enzyme inhibitor can increase levels of drugs like phenytoin, carbamazepine, and valproate. Ethambutol, aluminum containing antacids, can reduce the absorption of ethambutol, and again monitor for gout attacks with pyrazinamide. A complete medication review before starting ATT is very essential. In elderly patients with chronic kidney disease, dose adjustments are critical. While INH and rifampicin often need no change, pyrazinamide and ethambutol doses must be reduced and often given thrice weekly when EGFR is below 30. These are the doses you can use, and I've given the adjusted dose also if the EGFR is less than 30 ml per minute. Unfortunately, outcomes are often poor. Delayed diagnosis leads to advanced disease at presentation. This translates to higher mortality, more relapses, frequent treatment interruptions due to toxicity, and an associated functional decline that worsens overall outcomes. Something about post tuberculosis lung disease. Even after cure, the battle isn't over. Post TB lung disease is a major sequelae, leaving behind residual fibrosis, bronchiectasis, and other structural damage for which there is no cure. Our management then shifts to symptom control, improving quality of life, and preventing complications. In summary, tuberculosis in younger versus older adults is almost a different disease. The pathogenesis shifts from primary to reactivation, the immune response from strong to blunted, presentation from classical to atypical, radiology from upper to lower lobe, sputum from positive to negative, drug tolerance from better to poor, and mortality is from lower to higher. So, what should you take away from this? TB in the elderly is atypical and a diagnostic blind spot. Any unexplained weight loss, functional decline, or confusion, think tuberculosis. Radiology is deceptive. Use molecular test and CT early. Always integrate a comprehensive geriatric assessment into your tuberculosis management plan. The title, The Great Masquerader, is apt. Our job is to see through the discues. Think tuberculosis even when it looks like something else. Let's be the vigilant clinicians our older patients need. Thank you for the patient listening. My references include the latest NTEP 2025 guidelines and textbooks like Hazard Geriatric Medicine.